Good morning, everyone. Thank you for joining us today. We are here to, I hope everybody had a wonderful, wonderful session at CHEST, and welcome to the last of the series of ILD solutions. Today, we're going to be talking about post-COVID-19 in patients with and without pre-existing lung disease. I want to thank the France Foundation for inviting myself and Dr. Higuero-Sevilla to discuss, or rather have a conversation exploring the impact of COVID-19 on ILD patients and looking at and focusing on what the potential ILD manifestations that may be emerging from post-COVID survivors. We'll be discussing what we know or what we have experienced and what we've learned about the natural history and potential treatment courses. So I'd like to introduce myself as well as Dr. Higuero-Sevilla. Dr. Higuero-Sevilla is a new member of the Yale Pulmonary and Critical Care faculty. He completed his medical school in Honduras. He was then internal medicine resident and chief resident at the University of Miami. Subsequently, he finished his pulmonary critical care fellowship training at the Medical University of South Carolina, and he's currently joined the Yale faculty as an assistant professor at Yale as part of the Yale ILD Center of Excellence and the Yale Post-COVID-19 Recovery Clinic. I myself, my name is Dr. Mridu Gulati. I'm an associate professor in the section of pulmonary critical care and sleep medicine, and I'm currently associate director of the Yale Interstitial Lung Disease Center of Excellence as well. Next slide. A few housekeeping notes along the way. Again, Dr. Sevilla and myself would like to thank the France Foundation for inviting us. We would also like to extend a thank you to Boehringer Ingelheim for support of this educational activity. I also want to remind everyone to fill out the survey and the post-test to receive credit. Next slide. You'll have the ability to, on the right hand, please feel free to look for polling questions and fill out any questions and look at the conversations in the chat during the entirety of the lecture today. Next slide. So we're going to start with some pre-test questions just to get the juices flowing early this morning. So let's start with pre-test question 1. Which of the following scenarios has been reported in follow-up of patients with COVID-19 pneumonia? A, gradual improvement of symptoms and radiographic findings. B, persistent fibrotic changes. C, persistent radiographic changes suggesting an inflammatory component, including ground glass opacities. Or D, all of the above. So take a moment to think about that. And let's go to the next slide, please. So pre-test question 2, which of the following statements are true about patients with pre-existing interstitial lung disease who experience COVID-19 pneumonia? A, higher hospitalization rates. B, higher rates of ICU care. C, higher mortality rates. Or D, all of the above. Next slide. The final question, which of the following is the optimal treatment strategy for patients with persistent symptoms and radiographic abnormalities after SARS-CoV-2 infection who present to post-COVID-19 clinics? A prolonged course of corticosteroids. B, antifibrotics should be used universally in those with fibrotic disease. C, observation only. D, lung transplant referral. Or E, decisions should be made on a case-by-case basis with consideration of referral to a specialized interstitial lung disease center. So we hope to explore all these questions. Next slide, please. So to review the learning objectives, we will be comparing risk factors for and pathophysiologic features of ILD and post-COVID-19 lung fibrosis. We'll be discussing how we develop strategies for effective management of patients with pulmonary fibrosis and interstitial lung disease who contract and survive COVID-19 infections. And we'll be evaluating post-COVID-19 patients for fibrotic changes in the lungs after recovery. So we will be discussing all these. Next slide, please. So let's start with a case. So here we have a 53-year-old male anesthesiologist with a history of systemic sclerosis without any skin involvement. His background history included a prior history of interstitial lung disease, Raynaud's, and esophageal dysmotility. And he had been taking mycophenolate since his initial presentation in 2014. In 2016, he enrolled in a clinical trial for scleroderma patients with nintedanib and ultimately transitioned to the open label of the study. Next slide, please. We can see from this slide that he was generally stable over the years, and over a 2-year period prior to what we'll be talking about in terms of his COVID-19 infection, his forced vital capacity was relatively stable, as well as his diffusion. His CAT scan showed lower lobe changes with evidence of traction bronchiectasis and ground glass findings consistent with an NSIP pattern. So again, some symptoms of dyspnea, but relatively stable over time. Next slide, please. So at the outset of the COVID pandemic, we really didn't have a lot of information about how to treat our workers, as well as treat potential workers who are at higher risk for exposure. There were limited recommendations about what to do with patients with connective tissue diseases, with limited testing availability, and we did not have enough supply of personal protective equipment. Next slide. So for this particular patient, as I was making decisions in a relative vacuum, I considered that this was a healthcare worker with a higher risk for severe COVID-19 due not only to his immunosuppression and underlying ILD. He also had potentially higher risk exposures to aerosol generating procedures, including endotracheal intubation. So at the time, without much guidance, I made the decision, as he had been stable for some time, to discontinue his mycophenolate and continue the nintedanib. Workplace accommodations were recommended, as well as removal from direct patient care. Next slide, please. Unfortunately, in April 2020, relatively early on, he presented to the hospital with 2 days of dyspnea, cough, diarrhea, fevers, and new onset hypoxemia. Unfortunately, he had had a close contact to an individual at work in an unmasked setting while he was actually training for an alternative remote job position, reinforcing how little we had in terms of supplies early on in the pandemic. Next slide, please. So he was hospitalized between April 9th and April 14th. He had a low-grade fever. His saturations, although he had desaturated at home, he seemed to not go below 91% with ambulation, although he wasn't allowed to really ambulate very much at that time in the rooms. His CRP was elevated, a CAT scan was performed, and it shows evidence here of ground glass opacities in sort of the upper mid-lung zone fields in areas where you actually didn't have much pre-existing ILD involvement. At the time, we were still using hydroxychloroquine. We were not using steroids. And so we treated him at this point with hydroxychloroquine. Next slide, please. Post-hospitalization, he remained dyspneic and fatigued, but fortunately he improved after several weeks. You can see here, looking at his pulmonary function tests, that while he did not have much change prior to COVID versus after COVID in terms of his diffusion, his forced vital capacity did reflect the infection that he had had, and he had a decrease in his FVC that was seen even 5 to 6 weeks post-infection. And then again, it improved by the time he got to 5 months post-infection. Next slide. His CAT scan actually followed this as well. So we can see during the hospitalization, I showed an image of the ground glass opacities that were seen in the upper mid-lung zones. But again, 5 weeks post-hospitalization, he had a repeat CAT scan, and we can see tremendous improvement already, reflecting eventually what we would see in his pulmonary function test changes. Next slide. So at this point, how do I treat him after COVID? And at the time, again, we had very little recommendations in terms of how to reinitiate immunosuppression for rheumatic diseases after COVID-19 infection. In this particular patient, I did pursue a test-based strategy and actually did repeat his COVID-19 tests, as that's what we were doing. And he had 2 COVID-19 tests that were negative before I reinstituted therapy. And we resumed the mycophenolate in May, and he returned to work remotely. Now we have more recommendations regarding what to do during COVID-19 infections. Generally, for patients with stable rheumatic diseases, we actually try to continue them on immunosuppression, and so I would not necessarily have had to have stopped him. I would try to minimize the dose of steroids, as higher dose steroids have been associated with worse outcomes. But for those who are actively infected, like the patient here, we would hold immunosuppressants during the COVID-19 infection, and for mild infections, reinstate 7 to 14 days after symptom resolution. For asymptomatics who are positive, 10 to 17 days after PCR positivity. And then for those with more severe infection, and these are the more difficult cases that we see, deciding on a case-by-case basis. And this, of course, may depend on the amount of immunosuppression, the type of immunosuppression, and the particular agents used. For example, rituximab, which may have a very prolonged immunosuppressive course versus a patient who's receiving, for example, mycophenolate or azathioprine. Next slide, please. So let's move on to another case. This is a 48-year-old male who was admitted between June 15th and June 28th with hypoxemia. He had what was called a mild COVID-19 infection in February 2021. In fact, he was treated at home and was not hospitalized. However, he never felt quite the same, and he eventually visited his primary care in April, and then was actually referred to pulmonary even before the hospitalization. Unfortunately, he never made it to that appointment. If you look at the chest x-rays on the side, in 2018, in retrospect, one can appreciate very mild, hazy linear opacities at the bases done in the setting of an upper respiratory infection. Not too much was made of these findings back in 2018, and nothing was really followed up on. You can see in April 2021, which he had an x-ray from his primary care because of progressive dyspnea, you can see an increase in bilateral hazy, reticular, and patchy airspace opacities on this x-ray. So again, this was before the hospitalization. Next slide. His hospital course, he required up to 3 to 6 liters of oxygen, although when he left, he was requiring 3 to 4 liters of oxygen. He had an extensive initial workup. His urine strep and Legionella infectious panels were negative. His CT scan showed evidence of lower lobe predominant peripheral bronchovascular interstitial lung disease with evidence of ground glass opacities, some architectural distortion, and traction bronchiectasis. So some features already relating to some potential fibrotic changes. Next slide, please. In retrospect, again, just like the chest x-ray I'd shown you on the other slide, we had the opportunity to review a CAT scan that was actually performed as part of a trauma workup after an MVA. And although these opacities at the bases were noted to be quote unquote atelectasis, the radiologist in close review and along with the pulmonary consult team felt that he had certainly evidence of pre-existing ILD that had not gone noticed at that time. And you can see the comparison between evidence of pre-existing lung disease for which he was asymptomatic to his June hospitalization, and we described these findings in the slide previously. Next slide, please. So what was his subsequent workup? You know, looking for causes and related associations, connective tissue disease associations for this particular patient, particularly since he'd had pre-existing interstitial lung disease. The workup was largely negative. He was an environmental health service worker. He had an extensive rheumatologic panel that was negative, and he had a bronchoscopy performed. Cell count was relatively unrevealing. Of interest, we were able to get a cryobiopsy, and although it's difficult to make a specific pathologic diagnosis of any type of many types of interstitial lung disease on bronchoscopy, in this particular situation, there seemed to be evidence of NSIP, as you can see, diffusely thickened interstitial septa with some evidence of inflammation, and also some focal areas of organizing pneumonia. He also had other parts of his biopsy which showed more fibrotic changes, which unfortunately I think reflected his particular course and later treatment response. Next slide. So subsequent treatment course, as we mentioned, we had the bronchoscopy, we treated him with antibiotic steroids, and he was discharged on prednisone 60 milligrams along with PJP prophylaxis. What I did not mention in the prior slide is there was some evidence of pulmonary nodules buried in the CAT scan as well, and an outpatient PET scan was suggested. So after discharge, he'd had the PET scan. It did not show any metabolically active lesions that we were concerned about. He was on prednisone 60 milligrams along with PJP prophylaxis. And unfortunately, at this point, he was requiring 5 to 6 liters of oxygen, particularly with ambulation. Next slide. So at this point, I'm in somewhat uncharted territory and wondering what to do with him. So what would your next steps be? Well, I can tell you that what we did in our clinic. Next slide. So I maintained him on prednisone 60 milligrams a day with PJP prophylaxis, which he had been on from discharge. I added mycophenolate as well, and I referred him expeditiously for lung transplant evaluation. Next slide. Unfortunately, before he was even able to pick up the mycophenolate, a week and a half later, he presented with hypercarbic hypoxemic respiratory failure requiring intubation. He was treated with antibiotics. He was pulsed with high-dose IV steroids, 1 gram a day for 3 days, and unfortunately had very limited improvement. Next slide. So at this point, we have very little treatment options. Although that being said, he was a young man with very mild ILD and really had no other medical problems and appropriate social support system. So at this point, next slide, ECMO was initiated after we called a local lung transplant center who was willing to take him. VV ECMO was initiated. He was transferred to the transplant center, and despite being there for some time, he continued to deteriorate and eventually passed away. Next slide. So what are some of the key questions and lessons learned from these particular cases? Well, there's some general questions. What is the overall prevalence and incidence of COVID-19 among patients with pre-existing ILD? Are they more susceptible? What is the impact of immunosuppression? And then secondly, are patients with pre-existing lung disease, do they have worse outcomes compared to the general population, or even for that matter, with patients who have other chronic respiratory diseases? Next slide. So in general, the incidence and prevalence of COVID-19 among patients with pre-existing lung disease, it has been, in early reports, relatively mixed. Low prevalence has been reported, for example, in a Belgium database of ILD patients where there only 1% of patients had been hospitalized early on in the pandemic. In another study looking at insurance claims from a Korean data set, there seemed to be overrepresentation of ILD patients, with 0.8% of patients having ILD compared to who had COVID-19 pneumonia compared to other patients. It's possible that our patients were much more careful during the pandemic and actually adhered more to infection precautions during this time, and this may explain some of the variation. Next slide. So what do we know about, in general, poor outcomes in patients with chronic lung diseases? And this was a nationwide retrospective cohort study from France of over 80,000 patients. And in that cohort, about 16% of those patients had chronic respiratory diseases, and 1.8% of those patients had interstitial lung diseases. And this is an example of some of the data that was derived from that study. They compared these patients to patients who had experienced influenza in previous years, and they also compared patients with chronic respiratory diseases to patients who did not have chronic respiratory diseases. And it seemed that patients with interstitial lung disease included, as well as many chronic respiratory diseases, experienced increased rates of ventilator-associated pneumonia, had higher rates of PE, and ICU mortality, not surprisingly. And among patients, compared to those who had chronic respiratory disease related ILD and those with influenza. So basically, COVID-19 patients with chronic respiratory diseases were doing worse than chronic respiratory disease patients who experienced influenza, and their complications were worse. The same, not surprisingly, was true in terms of chronic respiratory disease patients, comparing them to non-chronic respiratory disease patients and those who had COVID-19. And again, there was more ICU stay, longer ICU stays, more frequent ICU stays, ventilator-associated pneumonia, respiratory failure and mortality. And here you can see some of the examples here from interstitial lung disease, where you can see really high rates of ventilator-associated pneumonia, for example, 20%, versus those who had no chronic lung disease. And certainly, again, ICU stays 30% versus 14%. Some of these changes were reflected in other chronic respiratory diseases, while others were not. Okay, next slide, please. What other data do we have? Well, we do have some data suggesting that those patients with pre-existing ILD actually have worse outcomes than patients who do not have ILD. So in a study looking at electronic medical records at Mass General, Brigham hospitals, patients who had ILD had worse survival compared to those who did not. Interestingly, immunosuppression was not associated with worse outcomes. And while a UIP pattern was more prevalent among non-survivors, that finding was not statistically significant. In another European multi-center study, 49% of patients with ILD compared to other 35% of patients had a higher mortality. And in looking at that international study, we can see that patients with ILD who were obese, as well as patients with ILD who had worsened lung function, had worse outcomes, even worse outcomes. Next slide, please. So what do we know about acute exacerbations in pre-existing ILD? Well, there's actually not a lot of literature on this specifically. There are obviously patients with ILD who have COVID-19 have worse outcomes. But what do we know about what happens to these patients for those who survive and leave the hospital? Well, here's an example of one case report of a patient who had rheumatoid arthritis, who had actually discontinued immunosuppression, who really had very mild disease as evidenced in image A. Beforehand, it was not symptomatic, who developed COVID-19 as evidenced in the second image, image B, and was treated with steroids and ultimately discharged on 1 liter. Unfortunately, a week or so later, the ground glass capacities progressed. She became much more short of breath, and she was admitted again, requiring high flow oxygenation, treated with steroids again, and eventually improved, although she was still requiring oxygen. Now, the case that I presented here, the patient's COVID-19 was much more remote than his hospitalization in June, whereas this patient, for example, represented only a week or so after developing her initial infection. Next slide. So I'd now like to turn it over to Dr. Higuero to talk about interstitial lung disease in post-COVID patients without pre-existing interstitial lung disease.
Okay, well, thank you, Dr. Gulati, and thank you all of you for joining us this morning. As I take over and talk about ILD in post-COVID patients, I will remind you, as you know, as we go into our second year of the pandemic, this is a new topic and a field that we're learning as we go. As part of the post-COVID recovery clinic at Yale, I've seen many of those patients that get discharged after COVID and then will struggle and work on figuring out, is this ILD, and how do we define the questions in the patients after they have recovered from COVID. So let's just run through the cases. The questions that I would ask remind you, are not a best choice question because there's no standard treatment guidelines or standard diagnostic approach to this, but it's more of what we did and to make you think about what would have been your next steps. So first case is, this is a 46-year-old obese male with a BMI of 37, hypertension, hyperlipidemia, and asthma that was admitted with COVID in March of 2021. He presented after 10 days of fever at home, followed by dyspnea, hypoxemia, and was found to have a saturation of 70% on room air. As you can see from his X-ray, he has diffuse patchy opacities throughout the bilateral lung fields. He was admitted, treated with dexamethasone and tocilizumab. He was started on remdesivir, but this was stopped after 1 day due to abnormal LFTs. He had a complicated, prolonged course. He required intubation, proning, paralysis, and eventually went over to BV ECMO. Also, he had a left pneumothorax. he had RB failure from what was presumed to be a massive PE, but he was too unstable at the time to get a CTA, so he was giving systemic TPA empirically. As you can see, there's a chest CT from during the hospitalization in his acute phase, where we can see peripheral peribronchovascular consolidation, some areas of ground glass and traction bronchiectasis. Also, you'll notice chest tube at the right base. He was discharged to an LTAC. He gradually improved, came off ECMO, and actually was discharged to an LTAC after a 45-day hospitalization. So what do you predict was the outcome of this patient? And I'll give you a moment to think about it. So he was readmitted to the hospital a few weeks after for a ventilator-associated pneumonia and passed away from the complications. He has severe functional limitations due to dyspnea and requires 6 liters of supplemental oxygen, and he's undergoing transplant evaluation. C, he's mildly limited due to dyspnea and still needing 2 liters nasal cannula with exertion. Or D, recovery with improving radiographic findings along with resolution of symptoms and supplemental oxygen requirement. So again, wide different courses that we're charting out for you here. So what happened? So he came to the post-COVID-19 clinic actually 1 month after discharge. And I was pleasantly surprised to see that. So he was discharged after 2 weeks from the LTAC, was undergoing physical therapy. He actually had no respiratory complaints and was not requiring supplemental oxygen. His PFTs 3 months after hospitalization actually show just some mild DLCO and reduction and mild restriction. As you can see from the CT that was also 3 months after the hospitalization, he still has some subpleural bands and some mild areas of ground glass, but his CAT scan has significantly improved. This is to remind all of you that actually most of our post-COVID patients, as like most of the post-ARDS patients, once they survive the acute insult, they will gradually improve. So this is looking at what is persistent imaging abnormalities after COVID infection, because this is important as how we define ILD. So the persistent imaging abnormalities after a COVID infection has been reported in different cohorts at different timelines. Again, the longest follow-ups are 1 year, but as we can see in these multiple groups, varying from 3 to 6 months to a year, the most common finding in almost all of them was persistent ground glass opacities, anywhere from 37 to about 50-something%, and others reported fibrotic-like changes anywhere from 35 to 72%. And the rate of abnormal imaging in general was high. So we know that there's persistence of abnormal imaging, 40 to 72%, at least in these 4 cohorts I selected. But to remind you, what we call fibrotic-like changes post-ARDS, they actually improve over time. For the prior cohorts that I show you, how they define fibrotic-like changes varied. Some used only traction bronchiectasis and honeycombing, but also reticular changes or subpleural bands was also used to call it fibrotic-like changes. And here we see a case of a 51-year-old man that had severe ARDS secondary to H1N1. And just to illustrate, you can see the first CT 15 days during the course of his infection showed peripheral consolidation. He also had reticular opacities and had traction bronchiectasis. And 120 days out after his infection, most of these changes had resolved, and he still had some small areas of peripheral ground glass opacity, but significantly improved. So this is to highlight what we're thinking when we're seeing a patient with COVID ARDS and their scan looks terrible, and we're saying, oh, he has lung fibrosis. We have to be careful with that, because we know from ARDS and from the SARS literature that these changes can regress over time. And This is just a slide from a chest study from the Toronto ARDS cohort when they followed ARDS patients with imaging 5 years after their initial presentation. And although most of them had some radiographic abnormality, the predominant was ground glass opacities, they had interlobular septal thickening. What I would point out is that the average extent of the abnormalities was 5, 10%, 20s at the most. So this highlights that radiographic imaging gets better over time. In this study, they also showed that the rate of imaging abnormalities, that they were low and did not correlate with symptoms or any degree of functional impairment. So in the post-ARDS literature, we know that survivors have high rates of morbidity, but it's not correlated to imaging, which actually tends to improve over time. So this is the next case. It's a 61-year-old with a past medical history of GERD that was diagnosed with COVID late May of 2020, admitted to an outside hospital for 7 days after presenting with fever, dyspnea. It had oxygen saturation of 82% on room air. He required high-flow nasal cannula, was treated with remdesivir, convalescent plasma and tocilizumab, and was discharged on home oxygen, 2 liters with exertion. So again, his first-time evaluation, the Yale post-COVID recovery at 19 clinic was 7 weeks after discharge. His chest X-ray still has some patchy bilateral infiltrates, more in the mid and lower lung zones. And he still was having persistent dyspnea on mild exertion and was requiring supplemental oxygen, 1 liter. His ambulatory oximetry showed that he desatted to 87%. And he was still having significant severe restriction and a severe DLCO impairment on his PFTs 7 weeks after discharge. So he got a HRCT 2 months after his hospitalization. And you can see here pretty clearly that there are significant areas of ground glass opacities. There are also some mild traction bronchiectasis in the lower lobes, even 2 months after his discharge. So what would you do next? So A, bronchoscopy. B, start a course of empiric steroids. C, consider antifibrotic therapy. Or D, just wait and do serial PFT monitoring. What did we do? Well, he was referred for bronchoscopy with transbronchial biopsies. Wanted to see if he didn't have an infection, if there was anything that we're missing, if we wanted looking for organized pneumonia, and we'll get to that. So surgical pathology showed no specific abnormality. Cultures, AFB, NTM, and fungal were all negative. The BAL differential was not able to be performed due to cell degeneration. So at this point, he had persistent ground glass opacities 2 months. He appeared to have an inflammatory component in his lungs that we suspected might be something like organized pneumonia. And we decided to offer him treatment with steroids because he had persistent hypoxemia and dyspnea that was not improving over time. So he was started on prednisone 60 milligrams daily, and this was tapered over an 8-week course with symptomatic improvement. So this is his HRCT 5 months after diagnosis. And now it has interval improvement. He still has ground glass, but there's interval improvements of the areas of ground glass, significant. And we did a new follow-up now 16 months after his initial COVID diagnosis, and the ground glass continued to improve. Again, this is correlates with what we know about the ARDS, but we believe that by giving him steroids, this hastened the resolution of his inflammatory process. So this is his PFTs, how they show improvement over time. So you can see the initial PFTs from July, significant impairment, severe DLCO reduction, severe restriction, FEV1 of 52%. And by July of next year, 1 year out, his spirometry had normalized, and his DLCO, although it's still abnormal, had improved, and now he was moderately reduced only and almost double his initial DLCO. So again, post-COVID inflammatory interstitial lung disease, and you'll see we have no standardized definition about how to approach the nomenclature after COVID of all these changes that we see. And what we're looking when we talk about post-COVID inflammatory ILDs, we're looking for a steroid responsive condition after the resolution of the infection. The initial autopsy studies describe higher rates of organized pneumonia and acute fibrinous organized pneumonia, which are steroid responsive condition. This has changed in the follow-up autopsy studies that now describe predominantly diffuse alveolar damage. How much of this has been changed by the widespread use of steroids in COVID is something that we don't know. So I told you that from the literature of ARDS, SARS, we know that a lot of the imaging changes will improve over time. So you could argue, why give the patient steroids? He's just going to get better over time. And that's a question that we have. How long should we wait before considering an intervention? And like I told you, there's no standardized definition for any of this. Like, the best study that I found regarding this is, so for post-COVID ILD, the UK group by MILD describe a cohort of 59 patients that they define as post-COVID ILD by a multidisciplinary meeting approach, in which they interpreted imaging done 6 weeks after discharge. So they screened all the patients, and then once they reviewed the imaging 6 weeks post-discharge, they would say, yeah, we think this is ILD or not, and they would treat them with steroids if they had absence of reported improvement of symptoms, so they had weekly symptom screening, and if they were gradually improving on their own, they wouldn't offer it. But if they were not improving and they had presence of physiological and functional impairment as defined by a normal 6-minute walk test or DLCO, then they were offered steroids. The maximum dose that they used was 0.5 milligrams of methylprednisolone per kilo, and it turned out to be an average of around 27 milligrams tapered over 8 weeks. They reported actually improvement in symptoms, lung function tests, and imaging in all of their patients. So this is just to highlight what other groups are doing to try to better understand what is post-COVID ILD and what is its prevalence. So this is an initiative by the UK ILD Consortium that's ongoing, in which they hope to define what are the prevalence and risk factors of long COVID-associated ILD, and we'll see what data they obtain. So moving on to our last case. So this is a 50-year-old obese male, BMI of 36, no other past medical history, diagnosed with COVID-19 on April 2020. He had fever and dyspnea ongoing for 4 days. On arrival to the emergency department, he was immediately intubated due to severe respiratory distress. And you can see the chest X-ray there. He has like bilateral perihilar alveolar airspace opacities. So he had a hospitalization of more than 30 days. He required proning, paralytics, inhaled vasodilators. ECMO was considered, but ultimately not required. His treatment included tocilizumab, hydroxychloroquine. Interestingly, he was early on in the pandemic, but he got methylprednisolone because one of the treating providers thought that he might have a component of airways disease at the time in the initial course. So he ended up getting 8 days of methylprednisolone. And he eventually improved and was discharged on room air to a short-term rehab facility. He came to us actually rather late after his discharge for the post-COVID recovery clinic. We saw him 18 months out of his original diagnosis. He still has significant dyspnea and exertion, has not been able to resume work. His PFTs actually are not that abnormal with just some mild restriction. His DLCO is normal. He still has persistently abnormal imaging with reticular opacity, summaries of ground glass, and curvilinear subpleural bands. So what would you do next? So consider this. So consider tissue sampling, start empiric steroids, anti-fibrotic therapy, physical therapy, and evaluation for non-pulmonary causes of dyspnea. So what did we do next? So our focus at that point was, we thought that he didn't have what appeared to be a significant inflammatory component in his imaging. It was mostly parenchymal bands that we saw in his imaging. And with his PFTs, we thought that his symptoms were out of proportion to his PFT impairment and to his imaging, and that we were focused on outpatient physical therapy, structure, home exercise regimen, evaluation for other non-pulmonary causes of his dyspnea. I also would mention, which is something that we see in post-COVID clinic, but outside of the scope of this talk, or whole evaluation of post-COVID dyspnea, that is a symptom that's of high prevalence in our post-COVID patients, and dyspnea that is independent to PFT abnormalities or any imaging, for which we have developed a program that's based off evaluation with invasive cardiopulmonary exercise testing. But that's what we did. But it segues into, could you consider antifibrotic therapy in these patients, and antifibrotic therapy in general for post-COVID ILD? So the role of antifibrotic therapy is not defined yet. There are multiple mechanisms by which we know that post-COVID itself can generate pulmonary fibrosis, directly from cytopathic injury from the virus to that boliotrauma, barotrauma from the prolonged intubation. So, but we know that fibrotic-like changes, because most of this is defined on imaging, is a challenge because those changes can resolve over time. So it is unclear if post-COVID fibrosis is going to be progressive in certain cases, or if this is just the regular post-ARDS sequela that we just expect those changes to improve over time, and how do we differentiate those patients that are going to have some progression after? And again, it's unclear if the antifibrotics will alter the natural history of the post-COVID fibrosis in any way. But what are we doing to learn more about this? There are multiple clinical trials at this point. So these are some of the ongoing clinical trials for our 2 approved antifibrotic agents with nintedanib and pirfenidone. There are also other non-approved antifibrotic agents which are undergoing clinical trials for post-COVID fibrosis. Okay, with that, I will give feedback to Dr. Gulati.
Thank you. Thank you so much for that presentation, and actually just showing, I think it's really important for us to see the range of different cases that we are seeing. I think one interesting thing about the pandemic is, given just the huge burden of disease, even if it ends up being a small proportion of patients with either persistent changes or progressive changes, it's still going to really create a large burden of disease. So I'm going to the chat, and I see some questions popping up, and please feel free to add more questions. The first question, and JP, Dr. Higuero-Sevilla, I'm going to ask you to field this one. Do you use inflammatory markers like ferritin or CRP when you initiate a trial of steroids as an outpatient, or do you just start the steroids?
No, we have not used inflammatory markers at this point. It is interesting because our research group is actually collecting biomarkers on all of our post-COVID patients. So we might know more about that in the future. But right now, we don't have any data about good correlation with them. So we do the decision of steroids or not based on imaging, similar to the MILD group, persistent abnormal imaging, and functional impairment, no improvement of symptoms over time.
So, and I just wanted to add to that. I know at the beginning when the recovery clinic started at Yale, it was really unclear what is the panel of labs that should be ordered. And remarkably, I know that in talking to a lot of the providers in the clinic, that most of the providers were getting really normal inflammatory markers. And so given that most of these were flat, it sort of led to other decisions for other patients. So very similar to COVID, you learn as you go. Yep. With this. So that's part of the reason it's not being added. There are a couple questions about bronchoscopy, and I'm wondering, Dr. Higuero, what is your general approach to doing bronchoscopy as you're evaluating these patients who either have persistent abnormalities or symptoms? When do you actually do a more invasive procedure?
So, as we know, for looking for organizing pneumonia, transbronchial biopsy is not a great diagnostic approach given the lower yield. So normally we consider bronchoscopy if we think that there's a suspicion that there could be a concomitant infection or some other alternative process. But in general, most of our patients that come to the clinic especially the ones that were concerned for post-COVID ILD, still have symptoms, some degree of impairment. So they're not the best candidates for an invasive approach, or they're not going to be keen on an invasive approach. So in general, the rate of bronchoscopy has been low. I know that like the post-COVID papers I found from other groups, most of them have been doing the diagnosis based on imaging. Is that the right approach? We're not sure, but we're learning as we go.
Here's another question. What would the recommendation be for patients with minimal symptoms, but a significant decrease in diffusion and restriction on PFTs with ground glass 6 months after? So abnormalities 6 months after with impaired PFTs. How are you approaching those patients?
So minimal symptoms, but ground glass and impaired PFTs, that will be somebody that we will consider treating with steroids if we think that the degree of the imaging abnormalities accounts for their symptoms or for the degree of DLCO reduction. Although we're doing a pretty extensive workup on the post-COVID patients, so whenever they're quite symptomatic many months out, that's where our other approach of doing cardiopulmonary exercise testing comes in. But if 6 months out they still have significant ground glass, we will see if a trial of anti-inflammatory therapy improves that first before proceeding. Although I do recognize that one of the things that we always talked about is ground glass can also be fine fibrosis. So it might evolve over time and not respond to the steroids.
I mean, I think the other piece of it is what the trajectory, because I think in this particular question, the patient didn't really have much in the way of symptoms. So, the question is, what do you do with severe impairment, with significant impairment, but no symptoms several months out? I think it is a shared decision-making piece. I know that I've seen some variability in our clinic, whereas, even waiting longer than 6 months, even when there's pretty significant impairment, you still see some improvement. And so there is, I think there's been some variability. So even with impairment, I think a lot of times we're
we're
actually waiting the course out if they don't have a lot of symptoms or they're not required oxygen.
I missed that. So minimal symptoms, with minimal symptoms, we follow these patients. I have patients that now have been out more than a year, and there's just so much variability in the recovery of their PFTs that as long as the patient is stable, then we can just follow their serial PFTs in that case.
Here's another question. How often do you do a CAT scan post-discharge?
We do the CAT. We don't do it on everybody necessarily. We see a wide spectrum of post-COVID patients. So if the patient comes in and they're feeling better, their PFTs are improving, and we have little suspicion that they have any degree of significant impairment, we might just start with a chest X-ray. And if on follow-up after the initial visit, their PFTs don't either stop improving, then we'll consider doing a CAT scan to see if there's still some persistent abnormalities. But we don't have a standardized algorithm where we do a CAT scan on everybody. It's kind of a case-by-case approach. On the patients that are showing everything is positive and they're gradually improving, then we don't necessarily need a CAT scan just to prove that. We know that their clinical course will be good. It's more for the patients that are not improving either by PFTs or symptoms.
Here is, let's see here. We talked about the antifibrotics. So there's one question about the duration for vent support to start ECMO. In conversations with the ECMO team and the lung transplant team, I think for those with pre-existing ILD, certainly anybody with chronic lung disease, at least significant lung disease, was not getting offered ECMO. I think the difference in this situation is that, in the case that was presented here, is that he had pre-existing ILD, but it was very mild. And he was really failing vent support at the time. And so until we got because we don't do transplant at our center, until we got a commitment from a transplant program that they would expeditiously evaluate him, ECMO was not initiated. But I think certainly for a pre-existing ILD patient, it has to be a bridge, it has to be a bridge to something else. And that's kind of been, that's been the way it's been approached here. And I know we really didn't, I think the patient that we had here was sort of an exception in terms of having ILD and actually having the ECMO initiated. Let's see. Places for steroid pulse. So one question about steroid pulsing. Have you actually given any steroid pulses to patients, admitting them, or how are you actually, when you do start steroids, how are you actually starting it, and how long are you treating them for?
So we've been doing a milligram per kilo, anywhere from 0.5 milligrams to a milligram per kilo of prednisone, depending on how severe they are, and then we're just doing a short taper. Mm-hmm. So we've been doing a taper over 3 weeks. We think that if they have a residual inflammatory component after COVID, the infection has already resolved, which should be the driving factor. So a short course of steroids compared to like a standard organized pneumonia should improve. So that case I presented was one of the first cases that we did that ended up getting a longer course. But normally we do 3 weeks starting on average like 0.5 milligrams per kilo prednisone. So it's not a high dose and a short course.
Yeah, and I want to sort of emphasize in the pre-existing ILD patients that I've had COVID, who've come out of the hospital, who are either on low dose steroids beforehand or no steroids, I still try to wait at least 4 to 6 weeks before trying to be more aggressive and assessing for an exacerbation. And I do try to see if there's a rapid response. I mean, I have had patients who've exacerbated afterwards with the IPF pattern, in which I've, not again with a lot of data, in which I've added second agents to. And I do think the steroids have made a difference, although it's always hard to tell in terms of the tincture of time. In terms of other questions, how often are we seeing chronic thromboembolic disease or embolic disease in these patients? What's been your experience, Dr. Higuero?
We've seen in hospitalization, we've seen a lot of embolic events, I think, as everybody. But for outpatient, we haven't seen much of patients with manifestations of chronic thromboembolic disease. So they get their PE, but most of them recovered from it after COVID.
How often are you doing an assessment for PE afterwards for persistent dyspnea?
Case by case basis.
Yeah.
We're not doing it on a regular basis.
So for for the pre-existing ILD patients with persistent dyspnea that's not improving, I do order a CTPE. I've had one that's been positive, but for the most part, who didn't have it inpatient. But for the most part, they've been negative.
And I will highlight our experience from the post-COVID clinic is even patients that had some underlying chronic lung disease before COVID, the wide majority of the patients with persistent dyspnea has been post-COVID dyspnea, so a post-COVID condition being the driver of the dyspnea. This is the part where the invasive cardiopulmonary exercise testing has shown us that they have a peripheral limitation to exercise and hyperventilation as mechanisms of their dyspnea rather than underlying structural lung disease.
There's a question here about PET CT and deciding therapy in post-COVID. I'm not aware of any literature, and it's not something that we are actually doing, at least as far as I'm aware. Let's see if there are any other questions. Maybe it's organizing. Updated and tentative. Sorry, I'm looking. In terms of transplant referrals from have you sent anybody for a transplant referral from post-COVID clinic?
Not yet, actually not yet.
I'll do just taking or not taking antifibrotics. So as far as questions about immunosuppression, I think that I've not seen any differences. I'm not aware of any data, and at least a couple of the studies that I was looking at in terms of the impact on antifibrotics. It's not clear that the antifibrotics had any impact on outcome. And in some of the studies that I showed as well, there was not, as you can see, some of the studies for at least the pre-existing ILD, there was not necessarily an impact on immunosuppression. Now, that could be for various reasons. I think, many of us have seen, for example, in our rituximab patients, really prolonged infections and persistent infections in patients. So again, I think it probably is going to end up partly depending on the type of immunosuppression. Let's see here. All right, so I think I tried to answer a lot of, so as far as standard CT post-discharge, are you getting CTs of the chest on everybody who had COVID pneumonia?
No.
So my sense is you're doing a chest x-ray. Based on what the chest x-ray is, then you'll make a decision.
Yeah.
Correct, even if they have pneumonia?
Yeah, because we are getting most of our patients that get discharged with still some symptoms from the hospital. We get them they get referred to our clinic, but then by the time they get to us, a lot of them are significantly improving. So we'll get a chest x-ray, and if things look better, we don't necessarily scan all of them.
So I'm going to go to the next slide. There is one question I see about what to do with adding other immunosuppression for COVID inpatient. I am not aware of adding other types of immunosuppression like mycophenolate or anything else right now to those patients who we all have and are just sitting there. So just to long COVID, but no radiographic, are you able to get down to rehab? We do have, okay, so we actually do have a rehab program that's been developed for post-COVID patients and an at-home program as well, particularly for those who have some autonomic, who have some orthostasis as well. So they all see physical therapy when they come in for the first visit. And we are sending patients to rehab as well. So I'm sorry, we are kind of out of, I hope I could keep some of these questions, and I wish I could answer all of them. Just a minute on the post-COVID research that's happening at Yale. We certainly are working on it. We have a biorepository looking at biomarkers and immune phenotyping for fibrosis in post-COVID-19 patients, not just for this, but for all other chronic lung pathologies. Dr. Higuero already mentioned the invasive CPET, which has really revealed for those patients who really have normal, otherwise objective workup, have had reductions in peak exercise aerobic capacity and impaired systemic oxygen extraction. And so, you know, really kind of validating the fact that there is something going on with these patients, but it's a peripheral limitation as opposed to a central cardiac limitation. And then there's also a study going on looking at the impact of post-COVID conditions on work capacity, because it's been associated with so much burden, personal and professional burden for people in the community. So thank you all for joining. I wanted to put out a big acknowledgement to our team. I really want to thank our section chief, also a leader in the field of interstitial lung disease, Dr. Naftali Kaminsky. The Recovery Clinic program at Yale has seen over 670 patients at this point. It's a really extensive team. Dr. Jennifer Posick is the director of our Winchester Clinic, and Dr. Denise Lutchman Singh is the director of the post-COVID clinic. And then there's a relatively extensive post-COVID registry and research working group that working on all aspects of this as well. And really thank the hospital and the various other people who support the program, including the social workers and the patients and the advocates and physical therapists and all the other staff that make actually having this clinic and supporting these patients possible. So thank you again for joining today. And then just a reminder, in terms of recordings are available for some of the other sessions that were here. And please use, and then please comment, please complete the post-test evaluation so you can get your CME credit and MOC points as well.